All right, hey guys. Today we're gonna go over the case that we've done this week. We've done a 360 LippyLipo knees, calves and ankle, and 360 to the thighs. We did her first session on Monday and her second session on Wednesday. And I wanna kind of walk you through what we did, what we've done, because I found that a lot of patients, they have more or less very similar story. In terms of presentation, where they are, what type of lipedema, how many sessions they need. And I'm gonna address all that stuff here. Let me kind of write down here to write your questions below, and we'll get started shortly. That's perfect. So, and I have a list of questions that I got on here that I'll address as we go. So anyhow, to get started, our patient here, she's 49. About in 2019, she had liposuction done, again, by another plastic surgeon. And as you can see, she had liposuction for her lipedema, didn't get the outcome. When you take a look here, so you can see kind of like what they did on her. So they took fat out from that inner knee. You see fat was left here on that kind of anterior knee. They didn't address the outer knee. You see kind of where the entry point was for the liposuction, and she also had one here. On this side, they did liposuction here, but they didn't lipo here, and now she has that skin kind of like that's moving down. The ankle, the inner knee, all this is lipedema. As you can see, like that was after her liposuction. So this is kind of like how she was after our liposuction, which is like totally different. I mean, look how tiny her knee is. I mean, like perfect shape. You see kind of like nice as shape. Versus when you look here, you see kind of like boom, straight down. And that's very important. Like you gotta make sure like the knee and the lower extremity has to be the narrower point of that of the leg area, and then it goes down, and then you have the foot kind of the same thing on the ankle, as you can see, and I'll show you the back on her. But anyhow, so we end up like cleaning all that area, removing all the lipedema fat here, there, showing her kneecap, and transitioning to that. Her case was tougher because she had liposuction done before, so she had a lot of scar tissue and fibrosis, so it took us about 6 hours to do her, but she got an amazing outcome. So we were able to take her from here, kind of all the way to there. And that's kind of like the front side. She did great. I mean, she had a great experience, but with more scar tissue, more fibrosis, it kind of takes us longer during the case to get there. So let me kind of get some of the questions we have here, and I'm gonna start looking at it. So one of the questions we got asked from last week, kind of that I got is, if somebody is on hormonal replacement therapy, do they need to stay on it can they stay on it during the surgery, or do they have to stop? And I'll tell you kind of the short answer, you stay on it with LippyLipo. Now, if you're going to getting it on the general anesthesia or getting other surgeries done, then depending on the surgeon, they're very specific about HRT. And the reason for that is sometimes the hormonal replacement puts you at a higher risk for blood clots. Now, in our case, it's awake, there's no sedation, patients are moving, so the risk of blood clots more or less is like similar to the general population. So we tell patients, don't worry about it, you stay on it, because it helps. If somebody is on HRT, it helps them mentally as much as it helps them physically. So from my standpoint, like just stay on it, don't stop it, because the side effects of stopping it is actually worse than just being on it. But let's say somebody is getting like stuff done under general anesthesia because they worry about the DVT, the blood clots in the lower extremity, then for those patients, you want to stop the HRT. But if you're coming to us, LippyLipo, you don't have to stop HRT. The second question that we get asked about is the GLP-1 agonist, Wegovy, kind of this, I mean, tons of it, kind of like for the new generation medications for massive weight loss. And again, the question is, shall I stop it before my surgery? It depends who's doing your surgery, and it depends what type of anesthesia you're getting. Recently, the Anesthesia Association, they released that if somebody's going to go under general anesthesia, they have to stop them because the way they work is they slow down the gastric emptying, kind of like, you know, the GI tract system. It slows it down, so the chances of vomiting is higher, the chances of aspiration is higher, and if somebody's going under general anesthesia, it puts them at a higher chance of that happening. They were having more complication, and they say like everybody, they need to stop it weeks in advance before the surgery for that. Again, that's if somebody is going under the general anesthesia, getting different type of surgery, or if they're getting liposuction done under the general anesthesia. If you're getting LippyLipo done or liposuction done fully awake without any sedation, since you're fully awake, no sedation, there's no need to stop it. You can stay on it and kind of maintain it, because we found that a lot of people, it also helps them mentally. They are on a routine, they're doing well. They don't want to kind of stop what they're doing, so they're kind of continuously losing weight, they are on the right path, so you want to maintain it. So if you're getting LippyLipo done, you don't have to stop it because you're awake. It's like us talking, you're not getting any sedation, so we don't worry about the vomiting aspiration part of the that can happen with general anesthesia. So to sum it up, HRT, GLP-1 agonist, whether you know like Wegovy, I mean, whatever, there's many, I don't want to like mention all their names, any new generation, massive weight loss medications, there's no need to stop, again, because it's awake, there's no general anesthesia, you don't have to worry about the GI tract, you don't have to worry about vomiting, you don't have to worry about aspiration, so that you don't have to worry about all that stuff. Confession here is asking, what do you do about skin laxity? That's a great question. So our patient here, she's, as you can tell, she's stage 2. She previously had liposuction done, so they already took part of her liposuction out. And as you can tell here, she had already, her skin was kind of like moving down. So being stage 2, she's 49. So her skin, and I told her that during the procedure, probably it's going to be like 50-50 in terms of redraping. Now, when she lays down, you take the skin out of the equation, it shows you truly the outcome after the liposuction. But after a year, let's say if you want to decide on skin resection, you want to wait at least a year, because the skin, you'll be surprised how much it can redrape by itself. And we do a lot of like stimulation during the surgery, equalization. It's like microneedling in a way, kind of like inside out. But after the year, you want to see where that skin is, and then you're gonna make a decision. She is 50-50. She can go both ways. Somebody who's like, let's say, in their 30s, 35, stage 1, they're not gonna need anything for that skin, right? Somebody who's like 60 years old, stage 4, and I'm gonna take the other extreme, okay? Somebody 60 years old, stage 4, massive weight loss, 100% they're gonna need skin resection when they're done with their liposuction. Down the road, if they want like tight skin, they're gonna look great in clothing. When they lay down, they're gonna look great, but when they stand up, the skin is gonna sag. The other end of the spectrum, somebody who's 20 years old, stage 1, their skin 100%, they're not gonna need skin resection. And then everybody else is gonna be kind of on that bell-shaped curve. The people in the middle are actually our patient here. She's stage 2, late 40s, and she had some lipo done in the past and all that stuff, so it puts her on that. And time will tell. I'm like, if you go to the gym, make some muscles, try to kind of like increase the muscle under that extra skin, it will help redrape it better. But if her skin doesn't redrape well, wait for the year, because it will redrape some, and if it redrapes some, then you might not need skin resection. Most of the times, most of our patients end up not needing skin resection. From knees down, stage 2 minus, they do well, all of them. Stage 3 to 4, knees down, they do well. Knees up, that's where the laxity is. And usually where they see it is actually over that knee area when they stand up, because it's a cylinder. So think about it, we've made it thinner, and then so that cylinder goes down. And then people say, oh, what about that kind of little area of that's sitting above the kneecap when they are standing up? That's extra skin. And that's kind of like the treatment there is resection. But these are the patients who are later stages, older, massive weight loss, that fit more on that spectrum in terms of skin resection or not. Good question. We get asked about skin resection all the time. And truly, there's no like And because everybody is different, everybody is at a different stage of life, and some people have better skin quality, some people not, some people had massive weight loss, some people didn't, some people are stage 4, some people are stage 1, some people have Marfan's disease, some people don't. In our patient here, she also had Durkheim's disease, which makes it even harder. She actually had nodules. She has a nodule here that we had to remove, Durkheim's, or kind of like, she also had another nodule here in that upper area, and we had to do different things to be able to take that Durkheim's out. Confession is asking, what is recovery like? I'm seriously considering this and would travel to see you. Well, thank you. So let's talk a little bit about the recovery. So we did her on Monday. She finished. She's like, oh my God, she gave me a hug. She's like, I'm super excited. Like, she just like walked out. Okay, so I'm like, okay, great. And that's like 99% for a patient. On Wednesday, we did her second session, and always I tell patients, the second session, people are like, how is it gonna be? That kind of like anxiety a little bit higher. She actually was awesome, and different people are different. So she did great with the second session. She walked out smiling, and I was like, and that's kind of like, she's probably 90% of our population, of our patients are like that. So I would say 90% of the time, you're gonna have great recovery. Now, would you have swelling? 100%. Would you have bruising? 100%. But in terms of like the immediate recovery, I mean, it's like night and day, because I used to do those cases under general anesthesia, and people would be like, we would wheel them and we would get them out to the car in a wheelchair. They cannot stand up, get them from the wheelchair to the car, and so they get them the next day. Some of them needed IV fluid because of the dilation of the general anesthesia. With LippyLipo, I mean, they walk out, and I'm like, oh my God, it's crazy. It's just a game changer. So from a kind of like, truly like recovery, it's mainly bruising, swelling, and the pain kind of like in that area after the lipo. Usually it starts coming around that 24 hours afterwards, and then they go through we call it like a significant swelling the first 2 weeks. And different people swell differently. If they have skin laxity, they're gonna swell more than somebody who doesn't have skin laxity. So compression is key, MLD is key, all that stuff is gonna help. So you're gonna have swelling, you're gonna have bruising, but truly it's not like somebody is in a hospital for a week kind of after that, and which is crazy. Like sometimes we get there, especially from overseas, we see that all the time, and sometimes I get like patients like DMing me on Insta from like overseas, and it's like, oh my God, like is it true that like our patients are walking after the surgery? I'm like, yes. Why? Because like I'm here, I had the surgery done, and I'm like still in a hospital like a few days after surgery. And I'm like, okay. So the reason I'm saying that, because I was like, I don't know what to say, what to tell them, because I know what happened, but what can you do? Anyhow, so the key is recovery from that is different than if you had liposuction done, high volume liposuction, 10, 15 liters done in a hospital setting, whatever your starting hemoglobin is, how many team, who did the procedure, how much do you send, then you might have a very different recovery than our patient here. So with our recovery, it's mainly bruising and swelling. That's kind of the main recovery, and really kind of like some people are tender the first few days afterwards, especially around the ankle area, but the majority, I mean, they do very well. Now, I don't want to oversimplify it and say, but I tell you, every single patient that we've done this procedure on, they literally walked out of here with a smile on their face, like every single patient. So it's a game changer. So we love it, and they do as well. Kristen's asking, how far are you booking out of surgery? I stopped answering this question because every time I answer it, I get in trouble with Jerry. So I would just double check with Jerry for that. Because what happens is, because it's a very, the schedule is very fluid. And what I mean by that is sometimes like we get booked for like 1 year at a time. And then sometimes we'll have few cancellations. Sometimes rescheduling, like things happen in life, like a husband has unfortunately, terminal illness or this or, an accident. So schedules changes every now and then. And sometimes what happens is like, I would have people like, I need to get in because I'm about to get into menopause or I'm about to get pregnant and I don't want to like, I want to get treated before that happens. And I know you will book for like a year in advance. So I had to sit with Jerry, we canceled a few conferences, move things around and open few days for next year. This year it's fully booked, but for next year there's few days that are open. But I cannot tell you how and when, because every time I answer that, I get it wrong. So I'm not gonna fall for that again, because I'll tell you what happened. Once I told patients, yeah, we have some, and then actually we didn't have some. And it's like, oh, I thought you told me on the live that we had some. It's like, I am very sorry. I wish we had, but we don't. But anyhow, confession saying, that makes me so happy to hear that. Thank you so much. You're awesome. Thank you for being here. Let's keep on going here. I love doing those lives, guys. It just helps me a lot because I can share as much knowledge as possible to our patient. So to go back to the one thing that I found is, and if you're at home and you have lipedema, and a common presentation that I've been having is pain in the feet. Now we know lipedema starts affecting the ankle and it goes all the way up. We know that for the fact, right? Now, not everybody has ankle lipedema, because we have multiple types. You can have lipedema, but still the lipedema doesn't go all the way down to the ankle. Lipedema can stop here, or it can be just around the waist area. So if you're around the waist, you're type 1. If it goes all the way down to here, you're type 2. If it goes to ankle, it's type 3. So the most common type is type 3, is the one that goes down to the ankle. Then you have type 4, where you have arm involvement and forearm involvement, and you have type 5. So that's kind of from a type sense. So not every patient who doesn't have ankle fat deposition doesn't have lipedema. You can still have normal ankles and still have lipedema. So that's kind of something, because we've had some people like, I have normal ankles, but I cannot lose the weight. I'm having bruising, swelling, heaviness, tightness, all that stuff. And I was like, okay, send us your pictures. We take a look at the picture. I mean, hey, you've got lipedema. But I have normal ankles. It doesn't matter. You're a different type. The most common type is type 3 for lipedema, where you have the ankle involvement. But not everybody is type 3. Some people are type 1, type 2, type 5, type 4, depending on which type there is. And in all honesty, there's, I think, like 100 types of lipedema, because yes, we put them in like 5 types and 4 stages, but I've done hundreds and hundreds of these cases, and yet I have to see 2 patients exactly the same. Every person is different, the fat is different, the fat deposition is different, so they're very, very different. Let me get some of the questions here, and then I'll go to the comments. So confession is asking, so if you're traveling to see you, how soon after surgery can we fly home? 2 days. So I tell patients who fly from the United States, 2 days, 48 hours after. Even Canada, we tell them 2 days. For people who fly from overseas, like cross-Atlantic, 3 days. So just give yourself 1 extra day, because we had a patient where, because patients drain after the procedure, with more drainage, like she was on the about to board the plane, they wouldn't let her go in because she was having drainage. And it's like, oh my God, like, you're bleeding and stuff, and people just don't know, they're not in the medical field. So the patient knows, but the flight attendants and all that stuff. So I had to go on the phone with the physician there, all that. Long story short, they still didn't let her go in until the next day. So we learned the lesson the hard way. Now every time we tell our patients, if you're coming to us from Europe or coming cross Atlantic, then do 3 days afterwards. If you're flying within the US, and most of our patients fly to us, I say 2 days afterwards. So, and most of the times, like our patient here, we did her Monday and Wednesday. But most of the times we do them Tuesdays and Thursdays, so they are flying back on Saturday. If you want to stay 1 extra day in Nashville, then you can fly back on Sunday. But that's kind of like how, so 2 days is usually a safe bet. Chris is asking, I'm stage 1. I'm very concerned about not looking smooth after surgery. Good point. I've seen before and afters where contour and volume looks better, but cellulite and dimpling remain. Okay, so that's two very important points here, Chris. So the first one is, with stage 1, these are actually the hardest cases. And that's where people get in trouble with stage 1, because they think it's like, oh, it's stage 1, it's going to be very easy. Actually, stage 1 is very hard because the room for error is very narrow. So you have the muscle, you have the lipedema fat, and you have the skin. So if you're stage 1, let's say this is the thickness of the lipedema fat. If you're stage 4, that's the thickness, okay? So with that much room, that's less chances of error and contour irregularities there. Now it takes different skills for different ones. But let's go back to stage 1. Stage 1, you gotta make sure you're using the right cannula, you gotta make sure you're doing the right tumescent, you gotta make sure you're spending time to make sure it looks perfect at the end. Because if it doesn't look perfect on table, it's not gonna look perfect in real life, like 100%. You gotta make sure like it's like at least 4 to 6 hours on stage 1 to get the results you want. Otherwise, if you're doing it in shorter time, you're using bigger cannulas. Bigger cannulas on stage 1, more contour irregularities, more skin changes, more skin damage, more discoloration. So it's very crucial. You gotta go with somebody who has done tons of stage 1. He has or she has a lot of before and after on stage 1. Very, very tricky. Because the problem with stage 1 is if stage 1 is messed up, it's very hard to correct. Like our patient here, they messed her up. They did lipo on her, but I'm so glad she went to somebody who messed her up the other way around. They didn't over resect, they under resected. They were scared around the knee. You can see like they took fat here, you know, they tried to get like some fat here and there, but they're like, oh, I'm gonna stay away from knee. It's because they're not expert in that. And I'm glad they did that because I could fix her. Like, you know, I was able to get her from there to here, you know, like she did great. But let's say she's stage 1, and I've seen those cases, and actually we've consulted on these cases. We're like, I can't help you. If they over resected aggressive liposuction on stage 1, it ends up looking like a skin graft because you take all the fat out and now you have a skin adhere to a muscle. They get pain from it every time they're moving the muscle. Get skin discoloration. The vein dilates because they want to compensate for the lack of fat, the normal fat that should be present between the skin and that. And you can't fix it. The treatment there is fat injection, fat grafting. We know lipedema fat doesn't do well. Now you're taking lipedema fat from other places to inject it into the area that was over liposuctioned, and that contour would never look normal. Like, I promise you, like we've done it. It's just because like you cannot recreate what we normally have. So very important, and I'm glad you're asking this question. The other part of this question is I've seen before and afters where contour and volume looks better, but cellulite and dimpling remain. That's a good question. So contour and volume, the contour and the shape, to know like truly the value of the liposuction is you want to take the skin out of the equation. And the way to take the skin out of the equation, basically you lay down and lift the legs up just to see exactly how the infrastructure is looking, right? Or you just tighten and you simulate as if you're doing a thigh lift or skin resection just to see really the contour. So that to answer that tells you if they've done a great job. That's how, if I'm evaluating somebody who had liposuction done somewhere else, and I want to see did they do a good job on the lipo, is it a lipo problem or is it a skin problem? And that's how you can tell at home. You know, like, is it skin problem that I have, or is it they just didn't do a right liposuction on me? Like in her case, they didn't do a good liposuction on her. It's not a skin problem. She might have in the future skin problem after the year to see when she heals, kind of see where it is. But when I look at her now, okay, great liposuction, you've done great. Skin, let's see after a year what's going to happen to the skin. You need to fix both, okay? If you want skin tightening. So to go back to the dimpling problem, if you see dimpling, now the question, is the dimpling because they didn't do a good job when they did that? Or is the dimpling because a patient has extra skin, that extra skin will need to be fixed? And that's how you can decide. But without answering the first part of the question, what's the infrastructure after doing liposuction, you cannot answer the dimpling part. Because the dimpling part can be a result of bad liposuction, not smooth and that. So you want to have the pictures on table results. Like if you guys are getting any procedure done, make sure you get pictures of on table. Because if on table, like you look here and she has contour irregularities, it's not going to get better over time. You're like, oh my God. Like, so you want the on table results because that tells you the result of the lipo. And then the skin, you see it afterwards. I hope that answers your questions, but that's a very good question. Chris is asking, is LippyLipo and dual lipo the same? LippyLipo is based on tumescent anesthesia. Wall lipo is more water-assisted liposuction. It's a different technique that's done. Wall is more done in Europe. Tumescent is more done in the US, and there's different pros and cons kind of like of all that stuff. What I tell patients is the last thing you want to do is change what the surgeon is doing, because it's the painter, it's not the brush. So if you go to somebody in Europe and say, hey, you know what, like, you know, in the US, this guy, he does amazing work with LippyLipo, he's based on tumescent, look at his results, instead of doing wall, why don't you do tumescent? He's gonna do a bad outcome, because he or she might be better in wall than doing tumescent. So I would say connect to the right surgeon and connect to the right before and afters and connect to the right patients who went to that surgeon. And that's kind of like how I look at it. Because if that surgeon changes from wall to tumescent, the odds are he's gonna do a suboptimal outcome if he would or if he or she would have done it wall assisted. But at the end of the day, it's lipedema liposuction. It's LippyLipo to treat lipedema, and that's kind of and that's a very common questions, and a lot of patients, because you know, they talk together and say, okay, I got this, I got that, and they miss because there's a lot of information there. They miss the true important questions that they need to ask, because they can go, okay, what brush are they using? What's this? What did they do on the post-op? What's compression? What's that? Those are all important, but it's like down to the 80-20 rule. All these stuff is 20% of the outcome. 80% of the outcome is the painter, it's the person doing the job. The rest 20%, 80% of the talk is over the 20% of the outcome. So you gotta focus on what's really gonna get you the most benefit. That's a lot of things might help. You might use this compression over that compression, or this MLD technique over that MLD. I mean, they might add 0.5%, 1% maybe, but the true infrastructure is the person. Are they consistent in their results? Are they getting that outcome every time? Are they like that's the kind of the question that you want to go after to get the results that you're looking for. Great questions, guys. I mean, awesome here. So Kelly is saying no sounds. I'm not sure if you guys can hear me, but let me know. Confessions asking, thank you for doing these lives, very educational. I love it. I love to do it. I mean, that's that allows me to connect with my peeps, and I love it. Curly is asking, what's the price for the full leg? For pricing, so if you go to the link in bio and you kind of like fill the paper, because every person is different, kind of like different prices. So it's kind of like would change, but like as an interval, when you fill the paperwork, it will tell you kind of at the end, kind of like our prices, I think it's saying between 25 to 50 per session, depending on the person. If you're doing arms versus legs versus uppers versus lowers versus what's the medical condition, stage 1, stage 4, BMI, health risk, and kind of like that all factors in. But that's kind of like the price range in there. And the other question, I see another question here on price, kind of in there. When you go to fill that form, it kind of gives you an idea. Ada is asking, do we need to get diagnosed first before we come to you, or do you also do the diagnosis? With us, with LippyLipo, there's no need for diagnosis. You don't need an official diagnosis. I see so many people, they get them, so many patients that like, you gotta go see this, you gotta go see that, and this, and then confirm that. It takes them, like, they lose 9 months to a year just trying to get diagnosis. There's no need of that. It's just all like keeping the system working. You don't need that. Go over the previous live Q&As. You're gonna know if you have lipedema. If you have lipedema, you're gonna know it. It's not like, the same symptoms across most patients: swelling, heaviness, easy bruising, pain, heaviness at the end of the day, hypermobile joint. I mean, it's the same thing across patients. You put your picture, oh my God, I have legs similar. Look at all the before and after. Oh my God, these are my legs. I mean, and that's kind of how, like, you will be able, you don't need somebody to diagnose you. Like, there's no, you can if it makes you feel good, but it's not a need. Don't waste 9 months, a year of your life going to multiple specialists. Like our patient here, she actually went for somebody to diagnose her with lipedema, and I hope she's on the live. And they told her, I don't know if you have it or not, and actually I'm not going to document it that you have it. I mean, she's stage 2 lipedema type 4 with Durkheim's disease. I mean, like straightforward. She has all the signs and symptoms. Swelling, easy bruising, I mean, you name it, she has it. And she went down the cycle, and she had liposuction somewhere else, and they couldn't diagnose her. And it's just like, it's a system that's just not, at this point, it's not made to support the lipedema disease worldwide. I mean, 11% of women, they have it. And the knowledge in the medical field about that is like that much. The amount of disease we have is that much, like a huge gap. And unfortunately, the lipedema patients are trying to narrow that gap between the medical field and what they're going through. And that's the problem that we're facing. And that's part of these slides, just to kind of like narrow that bridge. Like, I mean, in 2019, I think she had her original surgery. So she was thinking about it before. She started to get diagnosis, this, that, until she found us. And then, so she booked, I don't know how many months in advance to get this. For yesterday, we've done her. So she's been like suffering through it for years to get to this point. So if I can shorten that gap for people, I mean, that would be great. And that's kind of what so to answer your question, Ada, you don't need that. You don't need diagnosis. Now, that being said, I find it somewhere for people who want to go down the insurance route and all that stuff and that, yes, they're going to have them to go to make it as difficult as possible and delay it as much as possible, which is ultimately the patient pay the price for that, to get them diagnosis and then to find them the physician and then to find, and it's like, and it takes years to get there. And you guys know how I feel about it. Okay, Chris is asking, when do you do stage 2, thighs, upper leg? How far up do you go? Is any part of the hips or butt included? So that's a good question. So most of patients, stage 1, stage 2, are usually done in 2 sessions. And the way we do them, we kind of split them. First session is usually, and normally we're doing, if somebody has a good blood count, they can tolerate doing 2 sessions in 1 week. I like to do that because it saves them on the travel time. This way, they travel here 1 week, they get it done on Tuesday, for example, give them a day break on Wednesday, and then do the other part on Thursday. That's how we do it. And then they'll be done with the entire lower extremities in 2 sessions. And if we're doing that, normally what we'll do is we do 360 lipo, kind of from the knees all the way down. And kind of like up to that. Now, it depends. Let's say somebody who has a lot of like kind of stage 2 plus towards stage 3, and they have a huge amount of lipedema fat pad sitting here, and I know I'm gonna hit the 5 liters, I might not do the spot here as part of the first stage. I will do it as part of the thighs. So I will do the outer knee, inner knee, outer knee, front of the lower legs, calf, ankle in 1 stage. So, because we have to be smart. The goal is to do the entire leg in 2 sessions if we can. So without hitting kind of like the 5 liters. And every person is different. So these questions, the answer is usually it depends because like the limitation on her was not the 5 liters. We took 3.2 liters out on Monday and 3.2 liters out on Wednesday. And look how awesome she looks. Let's say I want to maximize it. Like, you know what? I'm going to get 5 liters out of her. I'm going to give her an amazing outcome. You can take 5 liters out, but she would look horrible. She would be over resected. She would look like she had a skin graft, and she would just be miserable for the rest of her life. So the trick is to find really the sweet spot. Kind of to know exactly when to stop. Now, if she had asked me before the surgery, hey, how much you're going to take out? My answer would be like, I have no idea. What I have an idea is I know when to stop and when to, because knowing when to stop, this is where the expertise comes to. If you over resect, they get bad outcome over resected. If you under resect, you get like here. And the question is when to stop at a great outcome. And that's kind of really the question. So so I guess to put the question back is most patients, they need 2 sessions. Most patients, say 85% of patients, they need 2 sessions. Stage 3, 4, they would need more because the limitation is the 5 liters. Earlier stages like her, the limitation is the lidocaine. How much numbing medicine can you give in 1 session and how much the patient is able to tolerate in 1 session. Because remember, these cases are being done like 12 hours, right? Each is around 4 to 6 hours. So how much can you push being on the table without being overtired as well, for both the patient and the surgeon? Because like 6 hours of this, like when I'm done, I'm like swelling. The patient's like, I mean, like it's a full day just doing one case to get this outcome. It's not like, oh yeah, you just go in 2 hours and that. So you gotta factor all these in place to be able to kind of like really know how many we need. So in her case, 2 sessions. Most people will be 2 sessions. How is it staged? Depending on the body type. Most of the times we're doing knees down to the ankles on Tuesdays, and then the thighs all the way up to the saddlebags on the second day. In terms of the buttock, let me see if I can show you her back and we can talk. I don't know if the buttock is showing here, but okay, so just a quick thing about her back. I mean, again, here with liposuction done somewhere else to here. Unbelievable, like it's normal legs. That looks, when you look at it, this is a normal looking leg. This is a lipedema looking leg. And that's the difference, despite having liposuction done somewhere else. So that's kind of, now the answer is like, how far up do you go on the lipo? I mean, it's very important when we're doing the lipo, as you can see here, I mean, like perfect, normal, you go normal all the way up. So on the inner thigh, we want to go all the way up here. So I don't know if you can see, okay. So here, like you see there, I mean, you just kind of like, all that needs to go. All this inner thigh area, that needs to go. She didn't have much saddlebag area. If somebody has saddlebag, I like to treat it at the same time, because you want to narrow here the inner thigh and you want to treat the saddlebag. Because most patients with lipedema, they have like a more pronounced saddlebag area. And they also have kind of that, kind of the tire, kind of in the upper buttock. That is treated separately with a trunk liposuction. So the tire in the upper buttock that gives you kind of like the accentuated hip dip and then it goes to the saddlebag, that upper part is done with 360 of the trunk. The lower part, the saddlebag that sits below, I wish I had a higher, but her probably her, we call it C point, or the kind of like the dip, the hip dip is here. And then some people, they have like that saddlebag here. It's like S-shaped curve, where you have hip dips and then wide saddlebags. We see that with stage 3, lipedema, stage 4. She's stage 2, kind of like borderline. Some people, stage 1, they have it. So if they have saddlebag, that's treated at the same time with the inner thigh. Because the last thing you want to do is, you don't want to treat the inner thigh. Now that's going to look even worse in clothing, because it's a 3D and it's a visual illusion. So like patients going to look like they have even wider saddlebags, which they don't. So very important, saddlebag and inner thighs done at the same treatment during the thighs. Upper buttock tire area, that type 1 part, is done with a 360 trunk lipo. So I'm glad you're mentioning that, because our patient here, she was asking me, she's coming back to do her arms. And she's asking, she also has Durkheim's in her upper trunk area. And she's like, oh, can you take care of that with the arms? I would love to, but I'm like, I can't. And the reason for that is 2 different areas, 2 different treatment. Patchy treatment, spot treatments give you a horrible results. The body is 3D. So I'm like, when you do the trunk, you gotta do 360, you gotta narrow. You just treat one area, now you will get like exactly what they did. I mean, they just treated here, you can see it. I mean, they took that fat out from here, they didn't touch that, and not the right outcome. She needed that to be treated, she needed that to be treated, this fat part treated, that's treated, this small saddlebag here to be treated, and that's how you go from here to here. But when they do patchy treatment, you're not going to get the results. Now, yes, it's cheaper, it's this, it's that, and I get it, some people, they have to go certain routes. But if you want to get that, you want to treat the entire lower extremity, you want to treat the entire trunk, you don't want to patch it, because if you patch treat it, you'll get the patchy results. Good question. MZ Beyond is asking, easy bruising to your whole leg? Good question. I guess it depends. And let's talk a little bit about easy bruising and lipedema. So lipedema is not only a fat storage disease. Lipedema is a collagen disease. So that's why like any small trauma to the area, because the collagen, the wall of the vessels are fragile. So any small trauma to it, people get bruising. Now it depends on where the collagen is thicker, heavier or not, then people can get more bruising or not. So some people can have it in their whole leg, some people can be in the thigh. It depends on which area is they have those veins where they are superficial enough, where you can see the bruising and where the trauma is being get. But definitely easy bruising, we see it in most patients. Not every patient, but a large number of patients with lipedema have easy bruising. A large number of lipedema patients have swelling. A large patients of lipedema patients have heaviness of their legs at the end of the day. They have hard time walking. A large number of lipedema patients, they have pain in their feet, like pain. Like you just like, you know, they're like, and people got plantar fasciitis and other stuff, and probably it can lead to it, but it's just part of the disease itself. A large number of lipedema patients have pain on touch, like you touch their thighs, they're like, argh. Even when I'm marking them, I'm like, hey, I'm sorry, it's just gonna, or if I'm doing the ultrasound, I do ultrasound on every patient for the procedure. I'm like, hey, I'm just gonna push a little bit, because I know it hurts so much. And we see that in the most, not every single patients, but I would say 80% plus patients with lipedema have those symptoms. MZ Beyond is saying, I was told my legs are the way they are because it's muscle. Yeah, whoever told you that, they have no idea what they're talking about. I would run away, and it's so unfortunate. No different than our patient here. She was told that she didn't have lipedema by somebody who diagnoses lipedema. I mean, that's crazy what people come up to. Not instead of them saying, hey, I have no idea what you have, I don't know, let me look it up or send you to somebody who I think might have it. They come with some random excuse and some random answer that makes no sense. I mean, muscle, like the entire leg, it just makes no sense. Just instead of them saying, hey, I apologize, I have no idea, great question, I don't know the answer. As simple as that. But their ego is so big that they cannot answer it this way. They have to have an answer. Doesn't mean it's the right answer. So keep pushing if you like, and that's what I tell the lipedema patients. I'm like, just like keep going after the answer. It doesn't matter. You know, like if you think there's something wrong, keep going until you get the answer to your question. Don't take any answer. The thing is, you know, when we ask for the question, people like, you're gonna get an answer, unfortunately, but it doesn't mean that answer is the correct answer. And I'm sorry you had that experience, but so many lipedema patients, they went through that all the time. Or this is fat, or you're not dieting, you're not exercising, you're this, you're that, and then you're like, it's genetics, it runs in family, somebody in the family has it, 11% of women has it, and these people actually, they work out more than you do, and they're kind of like so athletic, so active, and yeah, they have great muscles. I mean, take a look at that, but it's covered by lipedema fat. But it's gonna take us time, guys, to keep on fighting so that we can get the word out there for lipedema and kind of get it to become a true diagnosis, a true disease where people like, you know, like the other day I had somebody who kind of like, you know, she mentioned on one of the posts, and I can't remember if I responded to her or not. She's like, oh, you know what, this is a big name to call like fat disease. I'm like, you know, my first thought, I'm like, you know, you're so ignorant, like you have no idea. You're attacking the lipedema community. First, go read on it. I mean, go, you know, just like try to read about it. And I was like, okay, well, it's autosomal dominant, affects 11% of women, pain, tender, boom, 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 all that stuff. It's a typical presentation of disease. It starts on puberty, gets worse with pregnancy, gets worse with menopause, and still up to this date, people are just kind of like, are haters. But it is what it is. We'll keep on fighting. Kelly is saying, love you, Dr. Salameh. I will forever be grateful to you. You're awesome. Thank you for being awesome. I don't know, you know how I feel about you. You're amazing. We had great. And that's the other thing, guys. Like when you do these cases a week, it's just so much fun because we get to talk, we get to laugh, we get to kind of like share things, and it's just fun. It's fun for the patient. It's fun for me. It's fun for the team. And and it helps a lot. We've been blessed by amazing, amazing patients, and it's been great. Thank you for being here, and I'm so excited for you, and looking forward to seeing you back. Others saying thank you. You're welcome. Let's keep on. MC Beyond saying, how do we set up a consultation? go to the link in bio, you click on it, there's only one place. It takes you to basically submit your paperwork for the consultation, and then I'll take a look at the paperwork and kind of will reach out to you for to schedule a consultation. And the paperwork, guys, is crucial to kind of like tell us truly kind of like what you had, and the photos are so, because as soon as I look at the pictures, I know exactly kind of like what you need, what other stuff. The only thing I won't know exactly for sure is like, is it one session plus, one session lower, depending on the ultrasound and the thickness of the muscle and fat. But pretty much anything else we can tell. The pictures are very, very helpful, and the bio, the link will kind of take you through that as well. Elise is saying, would you recommend a surgeon in the Middle East area, Lebanon? You know, I don't know of anyone in the world, not only in that area, who's doing LippyLipo. There's some people who are doing some sort of lipedema stuff, others are doing different things. But LippyLipo, no one is doing it. Like, no one. And that's, the learning curve is so crucial. We do have like some surgeons, sometimes they come to try to learn and kind of like figure that out. The problem that I've been facing, and I need to work on it to kind of really figure out how to shorten that learning curve, to be able to consistently deliver that outcome with great experience, both great results and great experience. And my biggest fear is get somebody in, try to teach them as much as possible, go so that they're doing LippyLipo and they don't have the skills, they don't have the personality, and then LippyLipo will have a bad name associated with it because people will be like, oh, I had LippyLipo and it was horrible, I had so much pain with that. It doesn't mean that the LippyLipo is not good, it means that the person that's doing it is just not good at it. And that's been like my biggest like fear of like, how can I transmit those skills and the knowledge and the experience to somebody who knows exactly how to take a patient like her to here, who's had previous lipo done, kind of at that age, at that kind of like, to get them to this level. And that's been my challenging part. So I've been very hesitant because I really don't know. And the last thing I want to do is like send somebody somewhere and then they don't get the experience or results or that, and then that bounces back on us. Don't ask me how I know. We've done it before, it happened to us, and since then I was like, you know what? I'm not gonna say anything because I have no control over what happens on the other side. In our clinic here, I have control. I see only one patient a day. That's it. People call us, oh, we want you to do this, you know, I want to have breast aug or regular liposuction. I'm like, no, we don't. We just have one patient a day. So I have control over it. Why do I want to have one? Because I don't want my patient to be waiting. I want my patient to go in. She's the only one in the waiting room. She's the queen of the day. I go in, I mark her. I spend as much time as I want with her. She can ask me all her questions. We can go in, take the entire time to get her the best outcome possible, show her the results, spend the day, walk her out, and have an amazing day. And that's what I have control over that. When I send somebody to another clinic, they're like, oh, there's like 5 other people in the waiting room, delay this, that, or the hospital setting. It's just like kind of like, so I'm very careful because what people are getting here are not getting in other places, and it's very hard in other places to do what we're doing because like we're so crazy that we just do 1 case a day. Very few, if any, person that I know is doing lipedema liposuction 1 case a day, only 2 days a week, just to get the best outcome possible all the time. I don't know of anyone. If you know somebody, please let me know. But that's how we're able to deliver those results, those experiences for our patients. And that's why our patients love us. I mean, we're a very boutique practice. We're very selective on whom we choose, and our patients are very selective on that part that they chose us as well. So kind of it's a mutual. I'm sorry, that was a long answer to your question, but that's how I feel about it. MC Beyond is asking, does being knock knee affect the surgery? I'm not sure what you mean by knock knee, but I tell you, I've had a few questions about people like who had Baker's cyst, ruptured Baker's cyst. It doesn't affect it because the Baker's cyst sits in a plane different where the liposuction is. People who had knee replacement, they say, hey, you know, I had knee replacement. I said, it doesn't. The problem with knee replacement is they would have more scar tissue, but we've done so many that we know how to go around it. The problem is that patient shouldn't have had knee replacement. She should have had 10 years ago her lipedema treated So she doesn't advance to knee replacement. Like our patient here, she's starting to having knee pain. She doesn't do anything about it in 5-10 years. Guess what? Stage 2 lipedema, advanced stage 3, stage 4 lipedema, more heaviness from the lipedema fat. She's gonna need a knee replacement, right? And then you do knee replacement on somebody with stage 3, stage 4, good luck with that. They're gonna need another knee in a few years because the problem is the lipedema. The wear and tear happened from the lipedema problem. It didn't happen just from aging. So if you change the knee, if you put a new knee on a lipedema patients who have stage 3, stage 4, or even stage 2, that knee is not gonna last as long as somebody who's like her, where you revert them back to normal. So again, that's kind of the answer of kind of the knee effect. Pawi is asking, is there a correlation between superficial blood clots and lipedema? That's a great question. We know there's a correlation between blood clots and lipedema. Even though, because we know collagen storage disease, the patients with lipedema, even though they have easy bruising, they're at a higher risk of blood clots. And we've had patients in the past who had a history of DVT because of their lipedema. So kind of like, now superficial blood clots, maybe. Again, the data is not there. Theoretically, there should be, if there is a correlation between deep clots and lipedema, then you might argue there is a correlation between superficial and lipedema, but the data is not out there yet. If I had to guess, most likely yes. The answer would be yes. Would we, now to take that further, would we do anything different from what we're doing? We wouldn't. Because again, LippyLipo is awake. Like you're totally awake, no sedation, no IV sedation. There is anesthesia, local anesthesia. It's like being at the dentist, so you're being numb. But there's no general anesthesia, there's no IV sedation, so the risk of blood clots is like significantly lower than somebody going under general anesthesia. Esther is asking, do you recommend lymphatic drainage massage for your patients? Absolutely. I think MLD, it helps patients on multiple levels. I like about the two things that I personally like about MLD. One, it gets rid of the fluid after surgery much faster than just by gravity and that. So it pushes things back to the lymphatics and kind of back out through the poke hole of the cannula. Because the less fluid we have, the less fibrosis we have, and the faster the patients get to their normalcy. So I like that part about the MLD. And the other thing that I like about the MLD is after the procedure, especially the first 2 weeks, like the first few days, patients are like, super excited. And then they go through kind of like, it's like postpartum, right? Postpartum blues. Most patients go through like post-LippyLipo blues, kind of the first like week or two, because they're going through the swelling, the bruising, this, that. So having an MLD that you can talk to, who's done that so many times, and most of them, because that MLD is treating actually many patients from different surgeons. So the MLD will be like, oh my God, like your results are awesome. I've rarely seen that. Who's your surgeon? So that gives patients reassurance. And that's kind of what I like about the MLD, the secondary effect of that from that. And then we see the MLD therapists are reaching out to us, and then we're kind of basically guiding them if they need guidance, or at least kind of thanking them from taking care of our patients, because I want to get the patients to get to where they need to as fast as possible. So I see the psychological benefit on the MLD side, not only from a physical improvement, but also psychologically. And the patient has somebody to go to talk to, and kind of like somebody who really understands where she's coming from. So yes, we do encourage MLD significantly after surgery. MC Beyond is saying, yes, you hit the nail on the head, what I have heard and experienced. Thank you. Elsie is asking a question, not in English. I speak 3 languages, so if you ask in English, French, or Arabic, I can answer it. But this language, I'm sorry, I cannot, I don't know how to read it. I am the real is asking, how much is this procedure? Link in bio. You'll see those. THT Fit is asking, what are the first signs? Good questions. It starts at puberty. We know that, and usually it's the coach at school kind of mentions something to to the girl, to the kid, I mean, the kids at that point, right? 12, 13, 14, that's kind of when it starts to happen. And then it gets worse with pregnancy, and then gets really worse with menopause. GYN surgery makes it worse, extreme stress makes it worse, any significant hormonal changes makes it worse, but it's usually the shape at a younger age. And kind of lipedema patients, they start kind of like, oh, my legs don't look like her legs, or my friend's legs are different than my legs. And it's usually internal, where the person is starting to see those differences. And they might say, oh, maybe I need to work out more, I need to do this more, or maybe it's muscle, or that's how I built, or my mom has it, my aunt, this, that. So they found an explanation, but in reality, they have lipedema. So Lady Jade is saying, I have lipedema on the right leg and lymphedema and lipedema on the left. So lipedema, that's a good point. So what's the difference between lipedema and lymphedema, and can one lead to the other, and vice versa? So lipedema can ultimately become lymphedema if not treated. So you can go from stage 1, stage 2, stage 3, and then ultimately you go to stage 4 lipedema. So this is kind of like the advanced stages. So the treatment there is still liposuction. However, if somebody is born with one-sided swelling, this is more lymphedema, and the other leg is normal. So if you have one total normal leg and one leg is swollen, then it's more likely to be lymphedema. Or if somebody had radiation or groin surgery or something on one side and they got swollen on that side, that's lymphedema. The treatment there is totally different than the treatment of lipedema or lipedema resulting in lymphedema. The treatment there on just the lymphedema part is lymphatic bypass, or where they take the lymphatic and then they hook it up to a vein, so all the swelling goes from the lymphatic system into the vein and back to the heart. Starting to lose my voice, so I take a few more questions, and then Dance is asking, the scars will be visible. I mean, you can take a look here. They would look like dots, pimples. We use like a tiny 2 millimeter thing that kind of get entrance to the entry side. But if you really look close, you will be able to see them. Most of them, they fade away after 1 year. That being said, that's probably, I would say, about maybe 5% of the population, where originally, especially the first 2 to 3 months afterwards, they get hyperpigmented, kind of more discoloration because the body is trying to heal. And these patients, as I say, hey, make sure that you have it covered, SPF 30 and above, no sun exposure, to kind of minimize that discoloration. Most of them, it's a discoloration, not like scarring or keloid, and we haven't seen that in lipedema population. It's not like a breast lift scar or a tummy tuck scar, and that they're usually like kind of pinpoint. So that haven't been much issue for us, but it's still like, if you really look for it and you know where it is, you'll be able to find it. MC Beyond saying, that's impressive and caters to the patient. Streamlined care, thank you. Dr. Slim is here, shout out. Zania saying, do you treat lymphedema late stage? Is it possible? I don't treat lymphedema. I treat lipedema that resulted in lymphedema, but lymphedema per se, lymphatic venous bypass, I don't treat those. I'll have those go to the specialist. Again, the key, guys, in medicine, the key in surgery, if you want something done, go to the person who only does that and the best in the world of doing that. And then if you want something else done, go to that person who only does that and the best in the world of doing that. That's how you ensure that you're getting the best outcome possible and the best experience possible. Knock knees is genou valgum. Okay, that explained. It's a condition in which the knees tilt inward while the ankles remain. Well, actually, so as you can see here, the patient, so we call it valgus deformity. That's kind of the word in medicine, and kind of like, that helps me. I guess that's the layman term, knock knee. So thank you for teaching me that. And let me talk a little bit about it, because that's a great example here. Most people end up needing knee replacement because of the valgus deformity. Valgus deformity or knock knee, basically that's what happens. So the legs, they started going outward, the feet start to go outward, and the knees start touching each other. And then patients become standing like that, kind of like knees together, and then like, so if you look at somebody who's stage 4, advanced stage lipedema, like the legs are so further out, the knees are touching the further out, and they're kind of like walk kind of funny, just because like they can't, because the knees are so much wear and tear because of the lipedema, and these people end up getting knee replacement that fails because of that. So the treatment is not the knee, the treatment is early treatment, recognize that, so they don't progress. So the valgus is actually a result of advancement in lipedema. The knock knees is a result of going from a stage 1 to stage 2 to stage 3 to stage 4. Let's say our patient here, let's fast forward 20 years from now. She's in her 70, 75. Guess what's going to happen to her? She'll probably going to be stage 3, stage 4 if she hasn't had that done, right? And then she's going to start deviate like typical stage 4 patients. She's not going to be able to walk. She's already having knee pain, and that's kind of the progression. And then we're like, oh, you have valgus deformity, or you have knock knees. Well, you don't. 20 years ago, you didn't, or 30 years ago. What happened is the heaviness of the lipedema, the advancement of the lipedema, put wear and tear on those joints, and then the legs to support that knee, they started deviating to the outside. It's like having a house kind of like on 2 pillars, and then the pillars kind of like start to weaken, and then kind of like starts to separate. That's what's happening here. Great question. Vedit USA is asking, is it safe to operate on a 55-year-old? Yes, if you're healthy. Sometimes we have patients in their 30s where they're so high risk, where they say, hey, it's not safe to do it. And we've done it on patients in their 60s where they are very safe. So 55, you're fine. Actually, most of our patients are between 40 and 60 years old. About 80% of our patients are within that range. So you are in that window. And that's the other thing that I tell people about. If you're in the window, treat it. Perimenopausal, before menopause, just treat it before it gets advanced. Because if somebody comes to us at that, let's say the age of 70, and they have that long of medical list, they're beyond that window. The risk and reward is so much high risk to do that procedure because of what they have, then they lost their window. So if you're 55 and you're relatively healthy, do it now. Otherwise, it can be late in the game. Green is asking, do you do in California? I don't. We're based 1 hour north of Nashville Airport. And again, I'm like, everything here, we do everything in one place, we do one procedure a day, and that's how I'm able to maintain high quality and high experience for our patients. So, fly to Nashville. THT, thank you. VB is asking, are you in Miami? Again, we just not 1 hour north of Nashville Airport. Again, we get invited all the time to go and do surgeries and other places and that. We just don't. Again, to maintain high quality and high experience. I'll take this last question here, and I'll let you guys go. From Janine is saying, I had liposuction on my lowers and now have pain and tightness on the top of my feet. Do you know what that is? It's very hard to, based on what you're telling me, to know what that is. I need to see like your before, your afters, what type of liposuction you had done. My experience are, if you have had liposuction by somebody who's not experienced in lipedema, especially on the lower legs, that's probably the answer here. So it's very important, guys, like do your homework before you get the procedure done, because it's very different than somebody getting, like breast augmentation or whatever, tummy tuck or something where a lot of people do it. These are very specific skills that very few people are doing, and it's a very steep learning curve. So if you go to the wrong person and you end up with a complication or a bad outcome or that, like you were saying, it's very hard to correct. So very important to do your homework. And I'm happy to help you if you want to send us the stuff and that, and kind of join us on the next live and that. I'm happy to go over your case. We'll have you kind of sign the release so that we're not violating any HIPAA, and I'm happy to add, to help you in any shape or form. Kelly is saying, big shout out to Jerry and JC too. You and your whole team are the absolute best. Thank you so much, Kelly. And I have to say, like, Jerry and JC, they're like awesome. I couldn't have done that without them. They're amazing. I mean, they're like, they care so much about our patients. They're available like all the time, this, that. They're like superstars, truly superstars. Every case is perfect. Like every time I go in, I'm like, it's a perfect setup, guys. Like everything is perfect. Everything where is where it should be. It's nice and smooth. It's it's just a joy, and that's what I like to have. Like everything in one place, the same team, the people, they know me, I know them, we know our patients, and it's just a joy doing it. That's awesome. Jenny saying, have since had 3 surgeries in Australia with a specialist and happy. Thanks for the reply. You're welcome. And I'm so happy for you. Speto, thank you from Italy. Well, I love you guys. Thank you for being here. I'll let you go. If you have any questions, send us here, and we'll be going live every week. Our live time is usually on Monday at 12 p.m. Central Time, unless, like in our case here, we had a patient that we're doing on a Monday, then we would move it. But in general, it's going to be every Monday, 12 p.m. Central Time. We'll go live, answer any questions that you guys have.